It's a pleasure to be able to present to your audience. And what I'm going to do is to take you through what's occupied probably the last 10 years of my working career, researching a problem that is very common. And initially, we think, well, it's easy to treat, just give somebody iron, corrects the anemia, and everything goes away. But what I hope to show is that it's a lot more complex than that. And we really do need to be thinking more deeply about iron deficiency anemia in pregnancy so that we can provide the best care for our mums and, in fact, our babies. So I will be taking you on a bit of the journey that I went on. And at the end, we'll be talking about the trial that we are now running around the country. So first of all, anemia. I'm sure everybody has a picture of a patient who is anemic. They're pale, tired, lethargic, and generally feel miserable. What it actually is the number of blood cells are reduced in the bloodstream in basic terms. There are too few cells, and also in the cells, hemoglobin is what we talk about, and hemoglobin is the protein holding iron, is at a lower concentration. So those red blood cells, which have less smaller, fewer, and have less hemoglobin in terms of concentration, are not able to carry as much oxygen as they should. Now, in pregnancy, there's an additional complicating factor, and that is because the blood volume increases in pregnancy, the definition of anemia and the thresholds apply change across a pregnancy. So early on in the pregnancy, in what we call the first trimester, the threshold is set at 110 grams per litre. Below that, one is classed as anemic. Then in the second and third trimester, it falls to 105 grams because by then the blood volume has increased and diluted the blood cells. And in the postpartum period, it's set at 100 grams. Now, these occasionally change, and WHO reviews them from time to time and alters the thresholds. But these are the thresholds that are used in Britain currently. So what's the burden of anemia? Well, it is a huge global problem. There's 1.6 billion people worldwide who are anemic, which is a quarter of the world's population. And 30 to 40% of preschool children are anemic. Now, in a UK study, 10 years ago now, or over 10 years ago, 14 years ago, when 11 units were surveyed, they found that a third of women developed iron deficiency anemia during pregnancy in the antenatal period. In 2020, we used the NHS Blood and Transplant Services audit facilities and audited again around the UK to see what the prevalence was, to see if it had been reduced. And unfortunately, what we found, it hadn't. Still, about a third of women become pregnancy. And in the postpartum period, we found that 21% of the whole cohort were anemic. Now, we weren't able to get all the women tested, and of those who were tested, it was at 40%. So there is probably a much higher level of anemia after a woman has given birth. So what do we know? We know that it affects a large proportion of our population during pregnancy. It is most commonly, but not uniquely, due to a deficiency in iron, and we know that it is treatable and preventable. It's most often diagnosed, though, in the third trimester, and this is because of the way iron is used and the development of the placenta and the baby, which I will come to later. The diagnosis is complicated, not least because of the problems of hemodilution, but also because the diagnosis is not mapped accurately against outcomes. So the causes of anemia, as I've mentioned, iron deficiency is the primary cause, but there are others. So folate deficiency and vitamin B12 deficiency also cause anemia, but they are different types of anemia. The cells in those two types of anemia are larger, although they are fewer, and they have a different pattern. They are much less common than iron deficiency. There are also other groups of women who have special conditions like sickle cell disease and thalassemia or infectious diseases, which is obviously mainly occurs in developing parts of the world, like where they get malaria and parasitic infections. And they have much more chronic problems with anemia. And they are not readily amenable to simple solutions like iron tablets. For example, sickle cell disease often requires blood transfusions, and infectious diseases, obviously, again, as I mentioned, in the developing world, whilst they can be cleared, they often recur. So back to our own population, what problems does anemia cause? Well, most women, I'm sure those of you who have and care for women in the antenatal period, know that when they are anemic, they start to complain of lethargy and dizziness and fatigue. And they also talk of brain fog, which is an altered cognitive ability. More seriously, though, they suffer when at time of birth from postpartum hemorrhage. Now, this is not just because there are fewer red blood cells, and if they bleed, they do run into problems more quickly, which is true, but it's also because anemia itself affects the coagulation pathway. So if you are an anemic, when you bleed, you will bleed more and you will have a bigger effect because you have less blood volume to cope with the bleed that's occurred. We also know that women suffer more from infections, and sepsis is much more likely in somebody who is anemic. And finally, when we look into the postnatal period, there is good evidence that anemia or an iron deficiency anemia causes postnatal depression. We know that a deficiency of iron will alter the neurotransmitters in the brain, and as such, predisposes people to depression, and in the case of pregnant women, postnatal depression. And finally, there also it impacts on breastfeeding, which is reduced. For the baby itself, it can affect the growth, and we know that overall, babies of women who are anemic have low birth weight. They can be born prematurely. They can be affected by the PPHs that the mums have. And overall, the levels of mortality in women who have anemia are higher. And I will come on to show you some of the work and the results that we have found earlier in our 10-year journey. And finally, what's less well known, but evidence is now emerging, is that the infants of women who have had anemia in pregnancy also have delayed development. Now, this is because that in the first 6 months of life, if they are being breastfed, they are getting very little iron. And so the babies and children rely upon the iron that's transferred during pregnancy. So just a little bit first about iron, what it is and why it's important. So we know it goes to the formation of hemoglobin and carries the oxygen within the red blood cells. But it also has two other very important functions. The first is energy production in the mitochondria, which are the power stations of all our cells. And iron is required in the process that goes to create the fuel energy in terms of what we call ATP. Thirdly, it also is vital in the repair and translation of DNA. So our protein production is impaired when somebody is iron deficient, and DNA repair is also impaired. This has obviously serious consequences for cells at the same time when one's trying to recover from, say, surgery or an illness. So what are the iron requirements during pregnancy? Well, a non-pregnant woman will require 0.8 milligrams of iron a day to keep her iron levels at the correct level for her function. In pregnancy, though, by the end of pregnancy, she needs nearly 10 times more than that, at 8 milligrams of iron a day. And that's mainly because she has a big increase in her red blood cell volume of about 40%. And also the fetus and the placenta require large amounts of iron for their development. So in the third trimester and the late second trimester, the requirement for iron is extremely large and so needs to be delivered. Where is iron in the body, though? Well, it's stored in two forms. The main form is in ferritin, and the other is in hemosiderin. Now, the iron is stored in the liver and within cells. But the problem with ferritin, and we all talk and measure ferritin, is it can be influenced by several factors, and those are three there. But the big one is it is influenced by pregnancy itself, because pregnancy is a mildly inflammatory state, particularly in the early stages. So the evidence for the normal ranges of ferritin in pregnancy are poor, and this is why we rely on hemoglobin to diagnose iron deficiency anemia. Now, having said that, the guidelines do use ferritin, but the evidence for which they set the thresholds isn't good. And so we need to bear that in mind when we talk about treatment and prevention. Now, the big thing is, what do our women think about taking iron? Actually, they are a bit confused about it. They are open to social influences and very much take the advice from anywhere they can about what to do and when to take the iron. The consequences of taking the iron are there. They can sometimes get side effects. So they try to use their diet to increase the iron intake without taking medication. The sources of information can be conflicting, and so that leads to them being confused. They also talk to us when we surveyed them about the medical language that was used. So it was conflicting and sometimes information that they couldn't understand. We also talked to women who weren't taking iron and found out what they thought. They were relying heavily upon the diet and supplements that they were taking. And most of our pregnant ladies now take multivitamins with iron in. They found that it was difficult. They thought it was going to be difficult to take tablets and to arrange it around their life. And finally, their understanding of anemia was actually poor. They knew it was a problem, but it didn't think it was a life-threatening issue or had long-term consequences. So there is a lot of information out there that confuses people, and we do need to be more consistent in what we say. So can we increase the iron in our diets and avoid anemia? Well, in pregnancy, the answer is no, unfortunately. We can deliver more by improving our diet. So broccoli, meat if you're not a vegetarian, and various other things will improve the amount of iron delivered, but it will never meet the requirements in the third trimester of a pregnancy. And this is why pregnant women rely on their iron stores to deliver enough iron later on in pregnancy to the baby and the placenta. But we also need to remember that it's inhibited by certain foods. Absorption's inhibited by certain foods, such as tea. Drugs as well, like omeprazole and antacids, inhibit its absorption. So when we're giving iron, we need to be able to give good advice on how to take it, which is on an empty stomach, probably about an hour before eating or taking any medications. The absorption can be enhanced by taking vitamin C. So a drink of orange juice at the same time will help to improve absorption of iron. There are triggers in the body which will increase absorption. And without going into the technicalities of it, the liver is the control organ for absorption of iron. There's a protein called hepcidin, which, if it increases, stops the absorption of iron in the gastrointestinal tract. And it was thought that this could be used to really diagnose women who were short of iron in pregnancy. But unfortunately, we've done some work to show that that is not going to be the case. It is affected, hepcidin, by the iron stores falling, but also itself, like ferritin, by inflammation and pregnancy. Now, it is lowered and suppressed in pregnancy because obviously a pregnant woman needs more iron and needs to absorb more. So there's some physiological mechanism that goes on in a normal pregnancy to increase absorption, and it prevents hepcidin from interfering with that. So what about if we take a tablet of iron? What are the adverse effects? Well, they're well known as heartburn and indigestion, nausea and vomiting and black stools. Rarely there is anaphylaxis, but what people tend not to know is that there may be an increase in the risk of infections. It may alter the gut microbiome, which is the bacterial content, and it may cause preeclampsia. But the evidence for all of those is not good. It's poor. But as you'll see later on in this talk, we are going to monitor that in our trial to see if there is any signal that it may cause problems like that. So I'm going to move a bit into the sciencey area. And as I mentioned, we've been doing work on this over 10 years. And initially, we believed it was going to be easy to sort this problem out, just to get the treatment right. But what we found out is that's not the case. It's much more complex than we thought. So a warning, this is a bit of a warning, I'm afraid, for the sciencey bit that's coming, but I'll try to make it understandable. Our first piece of work was done when we looked at 2 years' worth of babies that were born in Wolverhampton. And what we found when we looked at the stillbirth rates was that for moderate to severe anemia, the stillbirth rate was 4 times higher than the background rate if you had moderate to severe anemia, which is a hemoglobin of less than 100. The units have changed since this work was done. And when I was first called about this, because we were collaborating with Oxford, and Oxford rang me up and said, "We're sending up the results. What do you think?" And I looked at them and I thought, "I don't believe this." So I forgot about it for a week. And then when I went back and looked again, I decided there is something here, and we thought we ought to find out more. So we got a second data set from London, Guy's and St Thomas's, and we increased the numbers to 14,000, and we found exactly the same. And this was incredible. We usually get excited about something if the stillbirth rate increases by about 1.5 to 2, but this was a fourfold increase in stillbirth rate. So we started to look why this was, and we thought, well, this is probably due to the oxygen carry capacity being lower, causing babies to be small, or causing them to have mums to have infections that causes preterm births. And this very complex slide, don't worry about it, it isn't those. It does not operate in the first trimester. If you're anemic, it doesn't operate through those mechanisms. There is an unknown mechanism of why, and if you're anemic in the first trimester, it increases your risk of stillbirth, but we don't know why. If you're later on in pregnancy, though, it probably does work through the mechanisms of low birth weight and prematurity. So there is a difference. The point here is there's a difference as to when you become anemic, as to what the mechanism is for being associated with this outcome of stillbirth. And we looked also then at low birth weight and preterm birth, and we found exactly the same relationship. So at the stage of pregnancy, you get anemia means that there is a different relationship in terms of what's happening and how it's causing problems. So another study we did was, because as I mentioned in the early days, we thought, well, we need to just treat this properly. It's badly treated generally. We found that from our national survey. So what we did was we looked at a cohort of ladies who had anemia in pregnancy. We took them out of the normal antenatal clinic, and we treated them almost religiously as we could by the British Society of Haematological Guidelines. Now, what that guideline says is that you treat women with iron, and then 2 to 4 weeks later, test them to see if the hemoglobin is increased, and there should be an increase by greater than 10 grams per litre. And what we found was that when we treated these women, and this was high dose iron now, 3 times a day, the number of women that were responding to the iron was 33%. So only a third of women increased their iron by the requisite 10 grams per litre. However, as you know, the threshold for anemia is lower in pregnancy, in later pregnancy. So we thought, well, some women were normalizing their hemoglobin, although it wasn't a 10-gram rise. So we classed those as responders too. But of those who we classed as responders, the number that responded was roughly around, there you go, 58 or 60%. So we were still finding that a third of women, or between 2/3 and a third of women, were not responding to oral iron during pregnancy. So this was telling us that even by sticking closely to the guidance, we were not able to prevent anemia in all pregnant women. What about side effects? Was it due to side effects? Well, not really. There were no significant differences in the side effects apart from black stools, and which were higher in women who didn't respond. So they were the ones who were not absorbing the iron. Now, these were women who were told how to take the iron, given all the appropriate advice, and so had the best chance of responding. So we were disappointed in treatment. So finally, we started what we call now the PANDA program. And we wanted to see if we could prevent iron deficiency anemia in pregnancy and improve the outcomes across the board in terms of low birth weight, preterm birth, and stillbirths. And our pilot study was to find the correct dose of iron to give to have the potential to do that. And these are the 5 hospitals that were involved in recruiting 300 women into this trial. What we found was, and we tested 3 doses of iron. One was a daily dose, one was alternate days, and one was 3 times a week. And what we found was that they all generally kept the hemoglobin higher, and they all had good levels of keeping above the threshold for anemia. So 95, 91, and 96%. However, when we looked at it more closely, it was the daily dose that was delivering the most iron. Because what we found, now I'm missing slide, is that when we looked at the number of tablets taken, The daily dose was five tablets a week on average, whereas the others fell down to 3 and 2. Now, why is that important? Well, if we wanted to see a clinical effect, we need to know that the iron is being absorbed and is being used. And we have laboratory data now that shows that alternate day iron and 3 times a week iron does not deliver the appropriate levels of iron into the body. The women react and they show changes that mean the body is requesting more iron. So an international panel actually looked at this data and said, you need to use the daily dose in your big trial. And this was an international panel that actually had connections to the WHO, who produced the original guidance. Now, we looked at the side effects again. So going back to the side effects of iron, and we found that when you looked at side effects, and we looked at all 4, so this is just to show you the anemia side effect. The nausea, the side effect of nausea. We looked at nausea, indigestion, heartburn, and constipation. And when we looked at between the different regimens for taking iron, there was actually no difference across the first and second trimesters into the third trimester for the pattern of side effects. The women were getting the symptoms before they took iron, and the iron made some of them slightly worse, but the changes were no different. So if you were only taking 3 tablets of iron a week, it was just the same as if you were taking daily iron. Now, we thought about this quite deeply and think that probably what's happening is that ladies are suffering from these symptoms before they ever get to take iron. They probably just assume they're part of a normal pregnancy and put up with them. And when they get iron, they get slightly worse. They tell their midwife, who then says it's down to the iron, quite understandably making that assumption. And so the iron gets a bad reputation and gets stopped. And it may be that that's part of the problem for treatment. The other thing that was happening, because we checked what was going on with the women and how they were going throughout the pregnancy, later on in pregnancy, they were more likely to forget to take the tablets in the alternate and 3 times a week arms rather than the daily arm. So going more specifically to treatment now, we know oral iron works. It will increase the hemoglobin, or it will maintain the hemoglobin. But there are other options, such as intravenous iron and blood transfusion. The intravenous iron is extremely expensive. And over a 10-year period, the use, and I only have Australia data here, has gone from $1 million to $80 million. The current strategy for treatment, as I've said, isn't working. About a third of women are still remaining anemic despite being given the appropriate treatment. And it may be that it's due to side effects, or it may be that they just forget to take the tablets. The timing and the frequency of the dosage, therefore, we would say, for our purposes, was once a day. So I'll just go on. But the caution with this is, obviously, I've mentioned there's concern that there may be some adverse effects. But as I said, I don't want to overplay these because I don't want us to worry any of our pregnant women. We've used iron for decades, and the work that's gone on to produce these theories has been rather poor. So I think I've made a case that prevention is better than cure because of all the problems we have with treatment and iron. I think I've made a case that our pilot data shows that it's a daily dose of iron that we need to test. And it's not just me that says this, or us in PANDA. The Americans in their Preventative Services Task Force came out and said the evidence for screening and prevention is poor and there needs to be trials. So hence now the PANDA trial. This is where we are giving, this is a double-blind randomized control trial. We're evaluating the clinical and cost effectiveness of a primary prevention strategy for iron deficiency anemia with a single daily dose of oral iron, which is 200 milligrams of ferrous sulfate, which delivers 65 milligrams of elemental iron. Most pregnant women are actually eligible for this, as long as they're not anemic or have one of the very rare conditions that can cause problems with too much iron, or iron itself can affect their diseases, such as ulcerative colitis or Crohn's disease. And we estimate that as a minimum, 70% of women in the first trimester will be eligible to participate. We have matched, obviously, the tablets. It's a double-blind trial, so there's a placebo and a ferrous sulfate tablet. The women don't know what they're getting, neither do we, and the tablets are identical. That's just to say what I've said. The schedule of assessments is very simple. We have made this trial as easy as possible. We use 95% is routinely collected data from the baseline through to 6 weeks post-delivery. We do not alter the management of the pregnant ladies themselves. We do not interfere with whatever the midwifery or obstetric teams do, and there are no extra blood tests. The only extra things for the women who participate are at 28 weeks, they are asked to fill in some quality of life questionnaires, and the same at 6 weeks post-delivery. Otherwise, we collect routine data. And as I said, we are monitoring whether they get preeclampsia or infections or sepsis, because we have to know absolutely that if this works, and it does reduce preterm birth, low birth weight, and stillbirths, and even PPHs and things, we have to know it's absolutely safe before it's recommended to the pregnant population. So those are our outcomes, as I mentioned there. We're also looking at the health economics, and we're also checking adherence, because in part of our earlier work, we developed an adherence intervention that helps women to remember to take the tablets and stick with them. There's a big team involved, and this is just some of the team. You'll know some fairly famous people there, Professor Marion Knight being one. And I really ought to acknowledge them, but more so, I need to acknowledge the participating units, of which some of you may be part. We now have 47 hospitals who've joined, and another 10 are in setup. But most importantly, I want to thank our volunteers. We actually have now, at the end of last week, 1,930 women who joined the trial. We need 11,000, so we are a long way off and have a big mountain to climb. But the pregnant women who are doing this purely voluntarily are really the heroes of the trial. And this is really citizen science in the real sense. And I think we need to pay tribute to them. It also shows what commitment there is from maternity units around the country to finding out a really important an answer to a really important question. And as we mentioned earlier on, with so much negativity around, it's easy to forget the good work that's done. And I recognize that the units that are participating are actually going over and above. And again, I want to say the thank you to them, as well as the participants from all the team in the PANDA. If there are people out there who want to join, we're still open for new sites. Please visit the website, which you see there. You'll get more information. We try to make that website reactive, so if you want any of the papers that I mentioned today, they're there in PDF forms that can be downloaded. I'll stop there, though, and see if there are any questions, and thank you, Sue.